Hello, and welcome to Voices of Wisdom, TIRO's podcast designed to share thyroid cancer pearls of wisdom from clinicians for clinicians. We invite international experts to share their wisdom, offering practical advice to clinicians in a variety of common and sometimes complex clinical scenarios. I'm your host, Dr. Dana Hartl. I'm an otolaryngologist and head and neck surgeon at Gustave Roussy Cancer Center in France. And it is a pleasure for me to welcome you to TIRO's Voices of Wisdom podcast. In each episode, I'm joined by a distinguished international guest who brings their unique perspective and expertise to the discussion. This podcast promises to be a pivotal resource in your quest for knowledge in the care of thyroid cancer patients. In today's episode, I am excited to be joined by Dr. Mark Zafereo. We will be discussing unresectable thyroid cancer, what makes a tumor unresectable, and we'll also dive into how advanced therapies such as BRAF and MEK inhibitors are reshaping the treatment and improving patient outcomes, particularly for anaplastic thyroid carcinoma. Dr. Mark Zafereo is a professor of head and neck surgery at MD Anderson Cancer Center in Houston, Texas, where he is section chief of head and neck endocrine surgery and associate medical director of the Head and Neck Center. Dr. Zafereo and the team at MD Anderson have been leaders in groundbreaking research in the use of targeted therapies for aggressive forms of thyroid cancer and particularly anaplastic thyroid cancer. His work and the work of the team at MD Anderson is paving the way for new treatment paradigms for differentiated and medullary thyroid cancer as well. Thank you, Mark, for joining us today.
Thank you so much for having me. What an honor to be here.
So you have a very unique knowledge, Mark, of unresectable thyroid cancer, particularly through your work and that of your team at MD Anderson involving BRAF and MEK inhibitor therapy for anaplastic thyroid cancer. Your work has completely changed the prognosis of anaplastic thyroid cancer, at least for patients with a somatic BRAF mutation. And this new paradigm is also being tested on differentiated thyroid cancer and medullary thyroid cancer with different inhibitors. So first of all, when you see a patient with a big tumor, it's obviously locally invasive with vocal fold paralysis, dysphagia, something that's sort of fixed in the larynx when you palpate it. What other clinical clues might you use to work up this patient, and what imaging do you prefer, or what do you go to right away?
To answer the question about what clinical clues I look for, well, first, I think, as we would all agree, it's important to listen to our patients. When we see patients with advanced thyroid cancer, we're going to be asking about symptoms of speech, swallowing, and breathing, or sort of the three that come to mind first. Obviously, speech in terms of, is this tumor, involving the nerve to one of the vocal cords, the recurrent laryngeal nerve? Swallowing, is there invasion of the esophagus? Usually, if there's superficial invasion of the esophagus, you don't really have much in the way of swallowing issues. But if there's true intraluminal invasion of disease into the esophagus in some of these really advanced cancers, that's when you start to get some more significant dysphagia. And then breathing, if there's airway compression, or certainly a case with bilateral vocal cord paralysis. So, and then quickly in these patients, we're moving to imaging. Well, of course, before that, we want to do a flexible laryngoscopy. We want to look at the vocal cords directly, and then quickly following up with imaging. We typically use a CAT scan with contrast and of the neck. And usually, because with these advanced thyroid cancer patients, distant metastases are common. The most common place of metastasis being the lungs, we just get a CT neck and chest together, just continue the cuts from the neck down into the chest so that we get a baseline look at the lungs as well. And then in some cases, depending on the biology of the tumor, we're also getting PET scans. Of course, we all know that ultrasound is tried and true sort of imaging modality that we use for all thyroid cancer patients. So we do use ultrasound in these patients as well, clearly. But in addition to ultrasound, CT neck and chest, and then sometimes a PET scan.
Great. So you don't go right away to a PET scan on these, particularly. You're going to wait to get maybe pathology on that. Sometimes we get these patients that come in and they've already had a PET scan, but maybe it's not necessary for certain subtypes.
Yeah, I think that's true. Oftentimes, when we see the patient, we already have the pathologic diagnosis. If we don't, certainly, one of the first things we're going to do is when they get their ultrasound, we're going to do an ultrasound guided fine needle aspiration biopsy with, typically either getting a cell block or a core biopsy to try to get enough tissue to be able to do genetic mutational testing. But once we have the diagnosis, then we can sort of make a decision about how biologically aggressive do we feel that this disease is, and is a PET scan warranted? I mean, as we know, anaplastic thyroid cancers with poorly differentiated thyroid cancers, those typically have high rates of distant metastasis. Oftentimes we'll be getting a PET scan. Those are very PET avid. Also, Hartl cell carcinomas are very PET avid. We'll often get PET scans for those, especially those that are local regionally advanced. And then, even local regionally advanced differentiated papillary and follicular cancers, if they're fairly local regionally advanced and we have high suspicion that there may be distant metastasis, sometimes we'll get PET scans on those as well.
Okay. Yeah, a question about, so you said FNA for cytology and then cell block or core biopsy. Do you have a preference? Do you have something like a protocol for these locally invasive tumors that you go to right away?
Well, I think oftentimes we're getting a core biopsy because that gives us the most tissue. But if an FNA cell block is done, typically that's enough at least to do some basic genetic testing, specifically like a rapid BRAF immunohistochemistry evaluation that you can hopefully get in a couple of days, because that's often for some of these advanced thyroid cancers that are either anaplastic, poorly differentiated, or papillary. Learning that BRAF status early is helpful. So I think we would probably have a slight preference for core biopsies because you get a little bit more tissue if possible, but the FNA cell block can work and you can get some genetic testing from that as well. So,
Oh, that's good. Okay, so it really depends on what's available as quickly as possible.
right.
So just to get back to the anatomy of these unresectable tumors, how would you define an unresectable tumor? Or on the contrary, how would you define a resectable tumor? Do you have a limit to how morbid surgery would be? Do you have like a checklist in your head?
So a lot of what we think about as resectable, as you may imagine, depends on the circumstances, right? And there's several different definitions of resectable that we may consider as surgeons. I mean, there's the strictly, is this disease technically resectable or not? Can we actually get the disease out with negative margins? And when we say, negative margins, we often mean an R0 resection, which would be complete removal of the tumor, or an R1 resection, which would be complete removal, but with microscopically positive margins. Can we get the tumor out with an R0 or R1 resection? Or is this going to be a case where, due to circumstances like if it's encasing the carotid artery, for instance, that then we didn't want to resect the carotid artery, that you'd have to leave a little bit of gross disease, which would be an R2 resection. So that's the first definition is this strictly resectable, technically resectable or not? When you're talking about that, I mean, there's a couple of factors that you typically look at. Carotid encasement is one. If it's 360 encasing the carotid, we very rarely would do carotid resections, for advanced thyroid cancer. I mean, I have done a couple of those, in my career, but it has to be a very unique circumstance. So typically, we're not doing that. So that makes a tumor unresectable in the vast majority of cases. Certainly, if there's tumor that's extra thyroidal or extra nodal extension that's involving the floor of the neck muscles, like into the scalenes and brachial plexus significantly, I mean, that's going to make it technically unresectable. Or prevertebral fascia. I have to say, prevertebral fascia is one of those areas where it's often equivocal on a CT scan. These thyroid cancers are often pushing up right against the prevertebral fascia. I would say it's very uncommon for those cancers actually to be invading into the prevertebral fascia. So just because it's like touching it, that's not unresectable. Most of the time, it's not actually invading there. But those are some of the areas where, certainly if it's extending into the mediastinum and you've got a nominate artery encasement, that's going to be another unresectable situation. So those are a few examples of what's technically unresectable versus what can be resected with an R0 or R1 resection. And then you get into the question of functional resectability or not, or based on morbidity. And so that's a whole different question that you have to consider. And that takes into account, a lot of factors, including the biology of the disease, patient preferences come into play. For example, you may consider a patient who has laryngeal involvement. that's invading into the larynx, that's, which would involve a total laryngectomy. In many cases, you may say that that's, unresectable, but it certainly depends on the circumstances. So there are cases where we do laryngectomies for patients with advanced thyroid cancer, but you have to look at the big picture, right? So if that patient also has significant distant disease, you're not going to want to do something that's functionally morbid for the patient, like a laryngectomy, when you're not going to cure that patient of the disease. Whereas in another situation where you have a patient that's very local regionally advanced, but no distant disease, and it's invading into the larynx, certainly you may have the option of neoadjuvant therapy in some cases to try to shrink the disease, to make it resectable without that functional deficit. But if not, you're making a decision to do that laryngectomy because you think you may have a shot at either, number one, curing the patient, or giving the patient some chance at more longer term survival. So those are a couple different definitions of resectability, the technically resectable and then the functionally resectable in terms of surgical morbidity.
Well, so that, of course, is all based on a multidisciplinary setting, knowing the biology, having already had the molecular biology results.
Yes, of course. I think when you're deciding, when you're making those decisions about resectability in terms of when the cancer is involving critical structures like the larynx, even the recurrent laryngeal nerve is another example. The resection of a tumor that's there are plenty of cases, as we know, where you can have tumor that's completely filling the tracheoesophageal groove, and clearly that nerve's going to be encased in tumor. You get a biologically aggressive tumor, it's filling the tracheoesophageal groove, right? Especially those that are right at the cricothyroid joint. You know that nerve's going to be encasing the tumor, but sometimes the nerve is still functional. The patient, the vocal cord is still moving. So you know that when you embark on that surgery, you're very likely sacrificing your recurrent laryngeal nerve. So those are a couple of examples of larynx, even a recurrent laryngeal nerve, where you have to look at the whole picture. You need to know what the pathology, the biology of the disease is, in terms of not only the histopathology. Is this a papillary? Is this a Hartl cell? Is this an anaplastic? Is this poorly differentiated? But also, what are the mutations? Because that, in 2025, that is such an important part of how these tumors may respond to therapy and what the prognosis is. And then, beyond that, what is the distant disease status? Because that's going to make a difference as well. So you put all that into the pot, and you stir it around in a multidisciplinary discussion, and then you make the best treatment decision for the patient.
Of course. Well, there are some scoring systems that have been proposed, and you do prospective clinical trials with the neoadjuvant that we're going to get into. Do you use a scoring system in particular? Do you have, or is it a checklist, or is it, because they haven't really exactly been validated, but they do have these different scoring systems sort of give a list of some of the structures that you mentioned that are the limiting critical structures that would give patients, for example, a very high bad score in these scoring systems. Do you use that prospectively in the trials, or what's your take on the scoring systems that have been proposed?
Yeah, well, the scoring systems are very much in their infancy. I mean, we're just trying to study these scoring systems for patients with advanced thyroid cancer, advanced thyroid neck disease. One benefit of them is really to try to see what difference we're making with neoadjuvant therapy. So there are several prospective multi-center clinical trials that we're doing studying neoadjuvant therapy. So we're using these morbidity scoring systems to determine, are we making an impact? So you basically evaluate a patient at baseline with the scoring system, and then you evaluate a patient preoperatively, and you see, as a surgeon, do we believe that this therapy that we gave the patient neoadjuvantly made a difference? And so that's the primary use of these types of scoring systems right now. And there are a couple of them that we're kind of using and studying in clinical trials. One of them is a very simplistic thyroid neck morbidity complexity scoring system, which we've published a bit on, and it's a very basic. Just oftentimes in medicine, simple is better because otherwise people will have a hard time understanding it and remembering it. So this scoring system basically just goes from 0 to 4. 0 being mild disease, 1 being moderate, 2 severe, 3 very severe, and 4 unresectable. And these, the 0 to 4 categories have different definitions of what fits into that category. And we look at that, we give it a score at baseline, we give it a score before surgery, and we see, did that make an impact? So that type of scoring system is not perfect. I mean, there's no perfect system in evaluating neoadjuvant therapy to see if we're actually making an impact, because even within the scoring system, there's ambiguity. When you're looking at imaging, you can't tell necessarily with certainty, looking at an image, either at baseline or preoperatively, are you going to be able to save a recurrent laryngeal nerve? That's, for example, I mean, you can't see the nerve on the imaging, where it is, but you don't know, is this disease going to be completely encasing the nerve? Is it going to be partially encasing? Is it going to be a case where you can microdissect the nerve off the tumor, or is it going to be like a nerve that's enlarged and discolored and clearly involved? So those are things that we can't tell even by imaging. And so it's not a perfect system by any means, but it's some attempt to see what impact we're making. And so I mentioned this very simplistic scoring system that we're using. And then also there's another scoring system that's a little bit more, has a little bit more complexity to it and detail and breadth to it, which has been worked on by Greg Randolph at Boston, Mass Eye and Ear, Rich Wong, Morrison Kettering, and myself at MD Anderson. It's called the MMM scoring system, which we're also looking at in clinical trials. So these are two different sort of scoring systems. They're very similar, but they have a little bit of differences in terms of detail and complexity. And we're in the process of trying to validate these scoring systems for advanced thyroid cancer. As you mentioned, they haven't been validated, but we are in the process of doing a study to try to validate these morbidity scoring systems for advanced thyroid cancer.
Well, that's really exciting. I mean, it's not going to become completely objective. There's always, like you said, some subjectivity about the tracheoesophageal groove and the recurrent nerve, but at least to try to get some objectivity on what's resectable and with what kind of morbidity. So that's exciting to hear. Well, so let's get to the neoadjuvant therapy. So for anaplastic thyroid cancer, as we know, it's the BRAF mutation. Is it just the BRAF mutation, or do you have other criteria for selecting patients that would be eligible for neoadjuvant therapy?
So the way that we think about anaplastic thyroid cancer in 2025 is, so there's really a divergence, as you sort of alluded to. There's the BRAF mutated anaplastic thyroid cancer, and there's the non-BRAF mutated. And I think ultimately, we may even, if we had a staging system that was, we do have a staging system that's a little bit unique for anaplastic, but if we had a more detailed staging system for anaplastic, I think that, ultimately, you could say those would be staged differently and that they'll have a different prognosis ultimately. So there's a huge difference in the BRAF mutated versus the non-BRAF mutated. So that's clearly the first step of the pathway in terms of, once you have a diagnosis of ATC, it's really determining that BRAF status as quickly as possible. And that's, typically most easily done with a quick BRAF immunohistochemistry exam from a cell block or a core biopsy. And oftentimes, we routinely send that IHC so that we get that result quickly. And then, the full panel of genetic testing can sometimes take a week or 2 weeks, but at least that answer within a few days, hopefully. If they are BRAF mutated, our standard treatment protocol is what's FDA approved in the United States, which is BRAF MEK inhibitor, BRAF and trametinib, and we also add pembrolizumab immunotherapy up front to those patients, starting about 3 to 4 weeks after the BRAF MEK inhibitor. There's been several studies that have been published out of MD Anderson that we've shown, and we believe that prolongs the response to the dabrafenib trametinib, the immunotherapy that is, and also you get a better response. So that's our data would suggest that. So we do use that triplet combination, and then we evaluate for the response and determine whether or not those patients should have surgery. Whereas when you're looking at the non-BRAF mutated patients, those patients are not going to have routinely robust or consistent response to therapy. So we do look at the mutations. Certainly, if there's something else that's targetable, which is not very common, but for example, if there's a fusion like a RET fusion or a TREC fusion, INTREC fusion, there are drugs that can target the fusion. So we would put the patient on a drug that would target that fusion. But aside from that, we're typically looking at something that's either RAS mutated, which there's not a particularly good drug that targets RAS at this point, although that's being studied, or really a lack of any targetable mutation. And those patients are typically treated with a combination of a tyrosine kinase inhibitor and immunotherapy up front. But the response is it's the best that we can do, and we do see some patients who have really good responses, but certainly not as dramatic and consistent as we do with the BRAF mutated. So I think the approach for these cancers is usually systemic therapy up front, depending on the mutational status. And then we do evaluate after a few cycles, of course, with frequent imaging follow-up, whether or not they're a surgical candidate or not.
So you look at all the patients, whether they're just on a multikinase inhibitor or something more, or BRAF inhibitor more specific. You do imaging later on, serial imaging, to see when and if the patient becomes a surgical candidate. And so my question was about how often do you redo, I imagine, a CT or PET CT in these patients? Is there a specific I'm sure there's a protocol. What kind of timing are we looking at?
Because these patients are typically, as we mentioned, on upfront systemic therapy, we're typically looking at it in terms of cycles. A cycle maybe every 3 weeks. If you look at 2 cycles, would be 6 weeks. And so I think our protocol is typically every 2 cycles at least for when we're looking at anaplastic thyroid cancer or even a very aggressive poorly differentiated cancer. Imaging every 2 cycles, so every 6 weeks. And we typically alternate between a CT neck and chest with contrast and a PET scan in those patients. So we'll get one at 6 weeks, and then at 12 weeks, we'll get the other one, and then sort of alternate those. And then we're, with those imaging modalities, we're evaluating the response, of course, local regionally. With anaplastic thyroid cancer, often these patients are presenting up front with either truly technically unresectable disease or functionally unresectable disease where you'd have to do a laryngectomy or something very morbid. So we're looking at that local regional response, and then we're also looking at the distant response, because that also plays a role into whether or not we're going to consider surgery or not, right? So we know that many of these anaplastic thyroid cancer patients have, and even aggressive poorly differentiated patients have, distant metastasis, upwards more than 50%. And so it's important to look at the local regional response and the distance response. And sometimes it's a uniform response across, local, regional, and distant, but sometimes there's some variability in response. But if we see, that at the 12-week mark, at least, which is 2 cycles, that patient is surgically resectable, and the distant disease is stable and controlled, then we offer that patient surgery. Obviously, it wouldn't make sense to do a surgery for a patient if you've got distant progression on the best therapy that we have, so we wouldn't do surgery in that case. But if we have a tumor that's technically resectable plus the distant disease is controlled, and that's when we move to surgery. And for BRAF mutated patients, I would say that roughly 70% or so will ultimately have surgery. They don't all ultimately have surgery. And the ones that don't are typically patients that are either progressing or just not responding well enough to do surgery, maybe even stable disease. But if you present with a tumor that's unresectable and you have stable disease, that's not going to be necessarily enough to be able to do the surgery. So there are a percentage of patients with BRAF mutated ATC who are what I would call sort of refractory to BRAF MEK inhibitor and immunotherapy. I mean, I think it's probably something like 20%. And those patients, may unfortunately never have surgery because they just can't be controlled reliably enough with systemic therapy.
Thank you for joining us as we have explored the complexities of unresectable thyroid cancer and the innovative strategies being used to make these tumors resectable. Our conversation with Dr. Mark Zafereo has been incredibly insightful. Due to the depth of this topic, we've decided to continue with a second part to ensure that we cover everything in detail. So don't miss out. Stay tuned as we continue this important discussion. If you have any questions or suggestions for future podcasts, please don't hesitate to email us at voicesofwisdompodcast@gmail.com. We have an exciting season coming up. Please stay tuned for future episodes. And if you liked our podcast, please subscribe to our webinars, which air live every Friday morning at 8 a.m. Eastern Time. TIRO Multidisciplinary Seminars is a series for thyroid clinicians and researchers that covers breakthroughs in thyroid cancer research and treatment in the form of topical journal clubs, state-of-the-art lectures, multidisciplinary tumor boards, and lively panel discussions. So just visit tyro.expert/subscribe or click in the link in the description.